Well, SCAAR is the abbreviation for Swedish Coronary Angioplasty and Angiography Registry. So it's a national registry established back in 1989. And at the moment, all hospitals that perform angiographies and angioplasties are reporting to the registry. So all 31 centers are reporting to the national registry. It gathers almost in real time information on each and one procedure that we perform in Sweden. We described every procedure by means of 250 different variables that describe patients as well as procedural details. And we can merge our registry with other registries, death registries, diagnosis registries, and we can derive a lot of data. SCAAR is unique. It's part of the Sweetheart, even larger registry collaboration that also incorporates heart surgery registry, secondary prevention, coronary care units, and so on. So by having this collaboration, we are able to create a high quality data prospectively, continuously, and what is unique is this national-wide construction that covers basically everything. There are no missing data in terms of which patients were part of registry and which are not, which is usually the problem with other registries worldwide. So in this particular study, we concentrated on patients with stable angina pectoris, as in contrast to patients with acute coronary syndrome, non-STEMI, unstable angina, and STEMI. So we ask ourselves, is there any association with the heart clinical outcomes in patients with stable angina if we use information available from FFR and IFR, coronary physiology indices, about the severity of lesions, and if we use that in our clinical decision making, compare when we use only coronary angiography as a source of information to decide which patient to treat and which lesions to treat and which should we not treat. So that's the basic setup of the study. So in one group, we had almost 22,000 patients where we based our decision making only on angiography. And we had almost 3,500 patients where we incorporated the information from FFR and IFR in the decision making. So that was the basic setup when it comes to the population we studied. The primary endpoint was long-term mortality. That's what was missing so far at this session, late breaking clinical trials, at this conference. 5 years data from FAME2 trial have been shown, and it's showing a significantly better outcome for patients that were treated with PCI based on FFR information. And our data are kind of in complementing that by showing even up to 10, 11 years, we still see the evidence of benefit, at least associative evidence of benefit in the patient in which we used FFR, IFR. So the most important part is that there was an association between use of EFR, FFR with the total mortality. So hazard ratio was 0.83, if I remember correctly, in the patients that were in the IFR, EFR group. The primary endpoint was decrease in mortality, this association, because this is an observational study. And the other secondary endpoint was decrease in risk of stent thrombosis and restenosis, also long-term, with a hazard ratio of 0.56, if I remember correctly. So these two hard endpoints were missing from the other randomized clinical trials. So Orbita, even if they performed FFR, EFR measurements, they were not used for decision making. So one could make an argument based on our data and the other studies that have been performed during this conference will be if Orbiter was made based on physiological parameters of lesion stenosis, and if they were incorporated in decision making, perhaps it will show from the beginning the superiority of PCI versus optimal medical treatment. And I think some of that has come up in the subgroup secondary analysis from the Orbiter that actually session started with the presentation from Orbiter. This is the largest study so far in this population, almost 30,000 patients, and it's real world data, and I will argue this is high quality data. I think what our study basically shows is it supports directly the current guidelines, ESC, ACC and HAI guidelines, that we should use this technology, this methodology more frequently in our everyday practice to decide which lesion to treat and which should we not treat. And I think it can improve long-term outcome. It can drive down the costs, improve cost effectiveness in our invasive therapy or vascularization therapy for patients with stable angina pectoris. That will be the take-home message from our study. So when we look in Sweden, we saw that back in 2005, when we started with, that was the starting point for our study, up to 2016, the average usage of FFR rose by almost 14% per year annually. So by now we are using it up to 40% compared to 15% when we started back in 2005.